we're going to see the difference between heparin and warfarin. So first, the mechanism of action is heparin will bind to antithrombin 3, and remember, antithrombin 3 destroys factor or inactivates factor 2, 10, but also factor 9, 11, and 12. So when heparin binds to antithrombin 3, there is inactivation of the coagulation factors that antithrombin 3 inhibits. Warfarin acts on the liver, and heparin acts on the blood or plasma. Heparin inhibits the epoxide reductase, vitamin K epoxide reductase, the enzyme in the liver that makes the vitamin K active, and so there is decrease in the synthesis of coagulation factors that are dependent on vitamin K. These are factors 2, 7, 9, and 10, as well as the proteins C and S. We'll talk more about this in a while. The administration route is for heparin is intravenous or subcutaneous, and warfarin is oral. The effect in the labs will be reviewed as here: increase in the prothrombin time, and here increase in the partial thromboplastin time. The effect would last for here some hours and here for days. The onset of action for heparin is some seconds, begins to act in seconds, and warfarin is limited the onset of action because the effect of anticoagulation in warfarin is in the coagulation factors that are not being created yet. It stops the creation or the synthesis of coagulation factors that are dependent on vitamin K, but there is no effect on the coagulation factors that are already in the blood. So for that, the effect of warfarin would be taken after the coagulation factors that are in the blood are destroyed. The reversal, that is, if we have toxicity of warfarin and we want to revert the effect, that is, the patient is, for example, bleeding, then here for severe bleeding we would use fresh frozen plasma or prothrombin complex concentrate. This contains only the factors that are dependent on vitamin K as well as protein C and S, and this contains all the coagulation factors plus vitamin K, because this will only address the acute bleeding, and vitamin K in order to truly reverse the effect of warfarin at the liver, because we're giving vitamin K. And if it is just like mild bleeding, we only give vitamin K. For heparin, to reverse this, we give protamine sulfate, because protamine sulfate is a positively charged molecule that binds to the heparin, that is a negatively charged molecule. The effects of warfarin would be it is metabolized by the cytochrome P450. So other medications that make more active the enzymes on the CYP450 or inactivate the enzymes would lead to a effect in warfarin. That is, for example, if we give a potentiator of the CYP450 enzymes, let's say phenobarbital, that increases the activity of these enzymes. If we increase the activity of these enzymes, we increase the metabolism of warfarin, and so there are decreased levels of warfarin in the patient's blood, and so there will be a decrease in the increase in prothrombin time. So we will see an increase in the prothrombin time as compared to previous giving phenobarbital. The opposite example is if we give erythromycin. Erythromycin is a inhibitor of these CYP450 enzymes. So if we inhibit the action of these enzymes, there will be decreased metabolism of warfarin, so increase in the effect of warfarin, so a increase in the prothrombin time and the risk of bleeding. So the patient should be very careful in taking medications that act on the CYP450. There is also displacement of warfarin because warfarin is an acidic protein and acidic molecule, and the acidic molecule binds to albumin. But the warfarin is very weak binder, so can be displaced, for example, other drugs that bind to albumin, for example, sulfonylureas, aspirin, phenytoin, etc. The effect on warfarin on the fetus is teratogenic, cause bone dysmorphogenesis, because crosses the placenta, so this could not be given in a pregnant patient. Heparin does not cross the placenta and could be given in a pregnant patient. The effect of warfarin about this in giving warfarin and heparin is, look, when the patient comes with a hypercoagulable state or for prophylaxis that we want to give heparin or warfarin, we want to give a anticoagulation, we would give warfarin, but look, the half-life of protein C is less than the half-life of, for example, factor 2 or factor 10. So when we give warfarin, first, before giving warfarin, for example, even though we give warfarin or don't, that is, the protein C is destroyed quicker than to factor 2 and factor 10. So if we give warfarin, we are inhibiting the synthesis of these coagulation factors and protein C and protein S. But because protein S is destroyed first than coagulation factors because of the metabolism of the patient, that is, warfarin only blocks the synthesis of these coagulation factors and these proteins. It doesn't have to do anything with the destruction or inactivation as heparin. No, here is just when the protein C is destroyed or gone, and we cannot make more protein C nor coagulation factors because of warfarin, there would be a moment in which there is only factor 2 and factor 10 and no protein C. So at the beginning, when we give warfarin, the patient is in a hypercoagulable state. So for that, while the coagulation factors 2 and 10 that are already made before giving warfarin are destroyed, before that, we need to give another anticoagulation in order to prevent this hypercoagulable state. So before giving warfarin, we always give heparin. Heparin or another direct thrombin inhibitor like dabigatran, fundaparin, etc. Usually heparin, and if the patient develops heat, heparin-induced thrombocytopenia, we change it to the direct thrombin inhibitors like fundaparin or dabigatran. This would present as necrosis due to the thrombosis, necrosis of the skin, for example. And obviously would be most commonly seen if the patient has protein C deficiency. That also puts the patient in hypercoagulable state. So because we give heparin and after warfarin, we usually don't see these necrosis due to the hypercoagulable state, transient hypercoagulable state that we produce when we give warfarin. Usually we don't see it, but if we see it, we should suspect a vitamin C, a protein C deficiency. But remember, always that you're going to give warfarin, first give heparin. And if you, besides that, you see the necrosis of the skin, and so we suspect in protein C deficiency. But if you give warfarin without giving heparin first, in cases, even though there is no protein C deficiency, we will see the necrosis. So it is very, very, very important to give heparin before warfarin. And usually the therapy lasts for 6 months, so the patient presents with a clot. If it is the first clot, maybe we don't treat it. Maybe we just treat it with heparin in the first clot, and that's it. but if the patient, or we already find that the patient has a permanent hypercoagulable state, like factor V Leiden, we give warfarin for 6 months after giving heparin. The exception would be the antiphospholipid syndrome, in which the therapy is lifelong.